Before we begin today's session, I'd like to thank the funders of Cochrane Canada, who provide support for systematic reviews, training, and research in Canada. That is the Canadian Institutes of Health Research and the institutes that you see listed there on the screen. I'd like to send in a special thank you to Louis Gabriel and the Pan American Health Organization, or PAHO, who provide funding for this license that we're using today. So again, I'd like to thank PAHO for providing support for Illuminate and for us to be able to provide these webinars. Today's session is on prioritization for updating Cochrane Reviews. It's going to be led by Sally Hopewell and Rachel Marshall. And I'd like to turn it over to them to start off today's presentation. Sally, Rachel, please go ahead.
Thanks very much, Erin. That was great. So my name's Sally Hopewell, and I'm going to be starting off this presentation before handing over to Rachel. Before I start, I'd just like to acknowledge Yemisi Toonga, Alex Sutton, David Tovey, and Bayesian for their work on various parts of this project, and also the funders, the NIHR in the UK, for providing funding. What I'm going to be presenting is a small part of a much larger project. So before we start, I'd like to start by thinking about what we mean by updating. And I've put a quote up here by David Mower. And he says that a distinguishing feature of an updated systematic review from a new review is that during updating, the originally formulated protocol, so the eligibility search criteria, is sometimes retained and sometimes extended to accommodate newly identified information. So, for example, new treatment types, diagnostic method, outcome, or different population. And this is the definition we're proposing when discussing updating Cochrane Reviews, and it's also the definition that's used in the chapter on updating in Cochrane Reviews in the Cochrane Handbook. So we know that failure to keep Cochrane Reviews up to date can lead to decision makers acting on out-of-date or misleading evidence. However, if we update too soon, it might introduce bias, as we know that those trials with significant results are more likely to be completed and published earlier than those with non-significant results. And so therefore the significant ones are more likely to be available to be included in our reviews. And as we know, updating requires substantial investment in time and resources. So if we update too soon, it's going to be an inefficient use of the resources that are available to authors and review groups in preparing and maintaining Cochrane Reviews. So current guidance is that Cochrane Reviews should be updated every 2 years. And this is based more really on the findings appearing current to the end user, rather than evidence that it's an appropriate time frame. But in practice, we know that reviews in rapidly moving areas are more likely to need to be updated more than every 2 years, and reviews where the evidence base is relatively stable might require updating less often. Just to demonstrate this, this is a study that was published in the Annals of Internal Medicine in 2007, and they looked at 100 reviews published between 1995 and 2005, and they found that 57% of reviews required updating within 5 years, and that 23% required updating within every 2, but that actually 15% of the reviews actually required updating within 1 year. So I think it's important to remember that updating doesn't just mean adding new studies, and that there may be other factors which we need to consider. So, for example, there might be new treatment regimes that are being addressed in an existing review that need to be considered, Or there might be new population subgroups, so it might be that it's actually this treatment's now being used in older adults rather than just younger. Or there might be new outcome measures or data from existing ongoing studies, or data that was previously missing that you've now got your hands on. And also systematic review methods might also need to be assessed to ensure that they're still appropriate and up to date, and that's quite poignant within Cochrane Reviews recently with the introduction of the new risk of bias tool and also summary of findings tables. And I think perhaps most importantly, we need to consider whether the review topic is actually still relevant and worthy of updating. So given the increasing workload of CRGs and review authors, we believe that there needs to be a change to the current practice of updating, replacing this rather arbitrary 2-year approach which currently exists. However, there is limited evidence to suggest the ideal time for updating, and uncertainty really about the best methods for assessing when and if to update. And there is evidence to suggest that it may not be possible to give a predetermined answer to determine when a Cochrane review should be updated. However, if you're monitoring the literature, I think is vital to gauge whether or not the research in a particular review area is moving at a fast or a slow pace. So if it's moving at a fast pace by monitoring the literature, it would reflect the need to update the review more often than the literature that was moving at a slow pace. And there's various surveillance methods that have actually been tried and proposed by different people to actually try and look at surveillance as ways of identifying new studies. And these include things like setting up auto alerts through the electronic databases such as in PubMed. You can also set up auto alerts within electronic journals. And some people have used the PubMed related articles feature as actually seeds for trying to identify new studies based on the three most recent studies. Citation tracking is also a possible option, and also obviously having a CRG's specialized register. So before we move on to talk about the particular tool that I was working on, I thought it was important to hear a little bit from you about your thoughts on updating. And I'm going to hand over to Erin, who's going to do a quick poll.
Thank you, Sally. So the question that Sally's asking is, have you been involved in updating a Cochrane review? So underneath the participant window, you'll see the green check mark and the red cross. If you could please just take a moment to indicate whether or not you have been involved in updating a Cochrane review. We'll give a moment for those answers to come through. And let's take a look at what our results are. So have you been involved in updating a Cochrane review? There we go. It looks like 43% have said yes, 21% have said no. So of the respondents, 2/3 have indeed updated a Cochrane review. So the next question is, for those of you who said yes, did you manage to update it within 2 years? So I've just cleared all the responses from the previous poll. If you could please indicate now, did you manage to update your review within 2 years? And we'll give a moment for those answers to come through. I'm going to send those results over to the whiteboard so that we can see what answers we're getting. And I'm going to turn it back over to Sally to let us know what she thinks about that.
Thanks, Erin. That's great, and well done on using the technology. I think that's really interesting to know that just under half of you have updated a review, but those of you that have updated, most of you haven't managed to actually do it within 2 years. I'd like to try and challenge the technology a little bit further and ask if anybody would just like to give us any comments on some of the barriers they found to not managing to update within 2 years. Now, you could do this by raising your little hand with the green arrow, or by just writing on the chat board. So I'll hand over and let's hear from you. I'll just give people a little bit of time. If anybody would like to tell us any of the barriers to updating. I mean, for me, the most obvious barrier is time, of availability of trying to get people to work on a review in time. Oh, just noticed we've got a challenge here from one of our authors. Oh, they're all coming in very quickly now. So some of the challenges people have said is about finding new review authors. 2 years comes around very quickly, yes I know it does. Changes in methodology, updating an orphaned review. Different RevMan systems. So I can see we've got quite a few challenges there. Would anybody like to be brave enough and actually comment a bit further by raising their hand and speaking? Not to worry, we've had another couple of comments. Lots of people finding things difficult. New risk of bias tool is quite difficult. Authors don't always get a new publication out of it. So I think there are a lot of barriers. And so what we wanted to do within our project is to try and condense, really, given this increasing number of reviews that need to be updated, we wanted to come and try and think about, well, was there a decision tool so that we could try and prioritise whether or not to update a Cochrane review. So, as I say, the aim of our project was to develop a decision tool to determine when Cochrane reviews should be prioritised for updating. And so we did this by trying to refine and amalgamate two complementary methodologies that existed for prioritising systematic reviews. One of these was a qualitative tool based on a broad range of signals, and one was some statistical methods which looked at when new studies were likely to change a review's conclusion. This is what our tool looks like, and I'm going to talk you through the different steps. There's sort of 3 steps as part of the decision tool, so I'm going to talk you through each of the steps. And before I do that, it's just important to say that this decision tool can be applied to a single Cochrane review, or it could actually be used to prioritise a suite of reviews, so for example those from an individual Cochrane review group. And if it's used to prioritise a suite of reviews, then the statistical element of the tool will actually rank the reviews in order of the probability that a review's conclusions will change based on the inclusion of new studies. And as I said, the decision tool has 3 steps, and an assessment is required at each step. So the first step up here is the clinical question answered, or is it actually no longer relevant? So if it's expected that there'll never be any further information that could change the conclusions of the review, or that the current evidence is deemed conclusive, or actually that the clinical question is no longer relevant, it needs to be discussed by the review team, because it's pointless putting resources into updating a review where the question's answered or it's a historical question. And so the decision could actually be made to flag the review as the current question is a current question but it's no longer being updated, or actually that it's a historical question and so therefore it's no longer going to be updated, and then actually to report that decision within the text of the review but actually make the decision to not actually go ahead and use resources to update that review. So the second step down here is whether there are actually any new factors relevant to the existing review that you would need to consider. So what do we mean by that? Well, as I said, are there any new factors relevant to the existing review? These might include information from existing included studies. So it might be that you have information about a new treatment regime, or information about harms, or a new population subgroup, or maybe long-term follow-up from your existing trials that would deem it necessary to update. People have said already new methodology, so the new risk of bias tool some people had said was a particular challenge within updating, but that might signify a need to update the review. Another example might be if you had a lot of crossover trials in your original review. We now know that there's methods that means you can use both parts of a crossover trial rather than just the first part, so that might be a trigger for updating. If you're getting lots of response and feedback from users of the review, or if it's going to be included in a recent guideline or policy guideline practice, that might be a trigger for updating. So if there are any of these factors, which we're calling signals, are identified, then a judgment needs to be made about whether or not that signal for updating is likely or unlikely to change the conclusions of the review. The third step is probably the most common step in the most common updating factor within a review, which is whether there are any new studies. And so if potentially new studies are identified, and remember we talked about the use of potential surveillance methods for trying to identify these new studies. So if any new studies are identified for inclusion in the review and in the meta-analysis, then we can actually apply a statistical prediction tool using data from these new studies. And the probability that this new evidence will change the results, the conclusions of the review, is calculated based on the size and the number of the new studies added. And our study showed that with piloting, a threshold of about 50% was sufficient to indicate the need for updating. This is what the statistical prediction tool looks like, and if you are going to use this, it's actually programmed using a statistical package called Stata, and so I believe this is something that should probably be done at a review group level, involving the review group statistician. It's very easy to use if you're familiar with Stata, but if you're not a statistician it might look a bit scary. But basically it's taking information about the size of the new study and whether or not it's likely to change the conclusions of the review. So the final step is taking all of this information that we've just talked about, so the new studies and any other factors, and whether or not it's likely to change the conclusions of the review and what we're likely to do. So if an updating signal that we talked about, one of those triggers, all new studies are identified, and it's deemed that it's unlikely to change the conclusions of the review, then the decision can be made not to update the review and that it should be flagged as current question considered to be up to date. And then what we're suggesting is the what's new section of the review should be updated, citing any of these new studies if it's appropriate and why they've not been included. And you could also add any details of these new studies to the studies awaiting classification. However, if you've identified a trigger or these new studies are identified and the tool says that it's likely to change the conclusions of the review, and most importantly that there's a review team available, then the review should be updated as soon as possible. If there's a review team currently not available, then the review needs to be flagged as a priority for updating. So, in conclusion then, we think this decision tool could aid the updating at an appropriate time and minimize the need for unnecessary updating. And The use of the tool could result in a change from the current guidance that Cochrane Reviews should be updated every 2 years to actually trying to employ a more evidence-based approach. So some reviews might be updated every 2 years based on the tool, some might not need to be updated for 5 years, and some actually might not need to be updated at all. And this should lead to improvements in the quality and the reliability of healthcare decisions based on best practice. So that's quite a lot to kind of go through and digest, but I just wanted to pause to see if anybody had any questions or comments. Again, you can write on the whiteboard, or if you feel brave enough, do raise your hand and speak. So I'll just wait for a few minutes while people have a chance to type in their questions or raise their hand. So we're just waiting. We've just got one person's hand raised. Now let me scroll down. Well done. I'm just going to hand over. I think Rachel's raised her hand, so I'll just pass over to Rachel.
Hi Sally, it's Rachel. I was just wondering, maybe you could provide some information to the participants about what type of information they need to extract ready for using in the tool.
Sure, Rachel, that's a really good question. What we're trying to do is to extract very minimal information. So basically what we're suggesting is that you're actually just looking at the abstracts as part of your surveillance. So you may have done a quick search on PubMed. And so what we're suggesting people do is scanning the abstract. So really all we need to know is how many participants were actually included in the study. And if we have information about how many events there were, so how many people had the particular condition, then that's good information as well. Does that help, Rachel?
Thank you.
So a couple more minutes just to see if anybody's got any other quick questions. Otherwise, I'm going to hand over to Rachel to tell you about the second part of the project. We have another hand raised. I'll hand over to Erin.
Thank you, Sally. I was just thinking about the whether conclusions are likely to change or conclusions are unlikely to change, and I wonder if you had maybe thought about incorporating grade in that, whether it might be worthwhile to grade the new evidence before deciding whether to do a full update and include the new study.
Thanks, Erin. That's a really interesting question. It's not something we have thought about because we've tried to keep it as simple as possible by basically just looking at the size of the new trial and not whether or not that it's a high quality trial or not. But that's something we could certainly think about, so thank you. Okay, so I'm going to move over now to Rachel, who's going to tell you about a project that she was involved in. So Rachel, it's over to you.
Hi, so I'm Rachel Marshall and I'm from the Cochrane Editorial Unit. And this project was funded by the same NHS Engagement Award that also funded Sally's part of the project on the prioritisation for updates. And this part of the project was looking at identifying Cochrane reviews that NHS stakeholders regard as the most important to update. And obviously this was part of our funding that we were looking to engage with NHS stakeholders, so that's why it's been targeted to this audience. But we would hope that some of the items that came out of this project would also be applicable to other regions and not just the UK. So as I said, we were looking to identify Cochrane reviews that NHS stakeholders regard as most important to update. But we wanted to not just develop a list of priority topics. We did want to come up with some kind of tool that could be used and wouldn't go out of date very quickly. So I should say that this tool was looking at how to prioritise topics rather than when to update, which is what Sally's tool was looking at. So this project was conducted by Bayesian, who were our co-applicants in the funding, and they had lots of experience of working with NHS stakeholders. And they're a for-profit company that looks at different types of evidence and synthesizing evidence. So they got a panel of 10 people together from the NHS, including clinicians, consumers, commissioners, etc. And they formed a panel for consulting with. And Bayesian held 2 meetings with the panel, and they communicated with them via email before and after the meetings. So before their first meeting, Bayesian presented to the panel a list of Cochrane reviews. I think it was around 8, and they just asked the panel to just start thinking about which of those reviews they thought were the most important to update and put them in a priority list. And then they gave them a questionnaire asking about what were the criteria they used when they were making that decision and how to rank those 8 reviews. So when they came to their first panel meeting, they talked a lot about all the different criteria that people had generated, and they discussed a more refined list and prioritising which of the criteria were most important for that panel. When they came to the second meeting, again, they went through and further refined the criteria, and they were also trying to think of how could we measure this criteria and how could we allow Cochrane review groups to make a measurement that this criteria has been fulfilled for prioritisation. And so after the meeting, a draft tool was developed in Excel. It was sent to the members for comment, and their feedback was incorporated. So I hope you can see this clearly, but basically the tool that was created from the project was a spreadsheet with 3 different sheets. And on this first sheet is the main scoring sheet. And as you can see on the left-hand column, the NHS stakeholders came up with 5 key themes that they thought were most important when prioritising topics for updating. And they were strategic importance, patient importance and impact, national spend, incidence and prevalence, and then emerging evidence and remaining uncertainty, which also overlaps with Sally's tool. And at the end we had some additional Cochrane criteria, and these are things that David and I had considered at the Cochrane Editorial Unit that we might want to consider, so it wasn't such a UK-focused tool, looking at things such as burden of disease around the world, whether the content is out of date, and also, as we've discussed, whether there's an author available for updating. So within each of these 5 topics, there were questions specifically around those topics that we thought perhaps could be measured and ranked. So we've got, for example, under strategic importance, presence on the QOF list, which is a UK quality framework list. And on the right-hand column, if your review that you were considering for updating was on the QOF list, you would assign it a 1, and then you would carry on going through your all the scoring and coming up with a score for the total of that review. And how we envisage this working is that it could be used over a suite of Cochrane reviews. Perhaps along the top bar you could have lots of different reviews, and then at the bottom you would have a total score for all those reviews. So on the second spreadsheet, sheet of the Microsoft spreadsheet, there's just a little bit more information around each of the 5 factors. So strategic importance is looking at things that are strategically important for the Department of Health in the UK. And there's obviously different things there for national spend. We're looking at not just the cost of the drug or intervention, but also the condition in general. And then on the third sheet, what Bayesian tried to do was find some links and URLs to guide Cochrane review groups as to where they could find this information. And unfortunately we have found that one of the links is already out of date, so we'll try and update that. But this is just to try and help people to define the evidence about whether it is, say, on the QOF list. So after the tool was developed, Bayesian tested it on a sample of 19 Cochrane reviews, and when they came to perform the judgments, I think they found, probably quite rightly, that there's a level of judgment that's required when making the decisions, and also that a certain level of knowledge of the field is helpful when assigning the scores. So as a consequence, it was recommended that the results of the tool are discussed within the CRG, and that could potentially include NHS stakeholders or people from outside the CRG, including patient representatives. So implications of how the tool could be used. So we discussed that perhaps the tool could be most appropriately used within a CRG prioritisation meeting. And this could be in person or it could be virtual. You could, say, ask members of your CRG to assign the scores and perhaps collate all that information together to see which of the reviews came up as top priority. We noted that the information required for scoring may need to be gathered before the meeting. You may not want to go through looking for all that evidence during a meeting, and perhaps it might be best to gather that information by an information specialist or researcher before the prioritisation meeting. But we thought that the summarised information could be discussed at the CRG, ideally involving information specialists, reviewers, clinicians, patient representatives, and other topic specialists. And then each review being considered for potential updating could be scored, and those with the highest marks identified as a priority for updating. And as I've said, this tool at the moment is very UK focused, but we could update this to allow possible adaptations. And some of the things that people had suggested when we were consulting the NHS panel was that you may want to weight scores for different questions. So you may want to have a higher proportion of your weighting go to patient importance than, say, strategic importance for the NHS. Or again, you could do something like Likert scales going from 0 to 5 rather than a 0 to 1 response to all these questions. You also might want to add or remove questions. So as I said, we added from Cochrane a couple of questions around whether the author is available or burden of disease around the world. But you might want to consider topic-specific questions for your CRG or anything else that might be appropriate. And the suggestion again was to modify the questions in order to concentrate on patient-defined outcomes. You might also identify that there are some key questions that meant you definitely had to update. So say you identified that there were new studies that you thought would change conclusions, that might lead to a definitely update decision rather than a definitely do not update decision. And we envisaged that we would have to keep this resource up to date and ensure that the links were still live. So that's it from my talk on the tool. So just wondered whether anybody had any questions or comments at this moment about the tool. We did quite a bit of thinking about how we might update it or adapt it. So we did think about questions such as, has the review been highly cited, or has it been highly accessed, which could be added on. Just seen that hand has been raised. So I'm just going to pass the microphone over.
Thanks, Rachel. This is Erin. One question that I was thinking about was when I was hearing the different stakeholders were involved. You mentioned the importance of stakeholder involvement a couple of times. Last week, Mona and I discussed applying the equity lens to priority setting, and I wonder if you might consider at some point when you're updating the tool, considering implications around equity or vulnerable populations in terms of involvement.
That's a really great question. I think certainly we could update the tool to perhaps ask a question around equity in the actual tool, and it would be great to have input on how that might be measured and scored so that CRGs could give a score for that. But also inviting people from vulnerable populations to be a part of the prioritisation process would certainly be a good way to engage stakeholders. I don't think we have any other questions from anyone, but I did wonder if somebody just put their hand up. No. I'll just hand over the microphone in case there's somebody waiting to talk. No, I don't think there was. So just to say that sorry about that. Just to say that there is now a poll, so I'll hand over to Erin to take the poll.
Thanks, Rachel. So a question for everybody who's on the call today. If you can take a moment to think about this. Are there any CRGs, CRG reps, CRG authors, anybody on the call today who's interested in trying out the NHS prioritization tool? If you can send through a green check mark to indicate yes or a red cross to indicate no, we'll just give a moment for those responses to come through. Just wait for a couple more of those. And for those who are indicating yes, it would be marvelous if you would be in touch with Rachel via email. We can provide that to those who've indicated yes on the call. Thank you very much, Rachel. There's Rachel's email right up on the screen. So if you could indicate that, it would be really helpful. And let's take a look at those results. I'm just going to publish those to the whiteboard and turn it back over to Rachel. Rachel.
That's great. So it looks like of those people who responded, there's a really great response to how this might be used. So if you did want to send me an email, I'd really like to talk to anyone who would like to use this tool. Just to let you know that at the strategic session, the Cochrane strategic session in Paris in April, there's a theme on Cochrane content, and I'll be leading a theme on updating Cochrane Reviews, and we'll be talking about some of the issues from this session, so Sally's tool and also this tool. So if anyone did want to use it before April and we could provide any feedback that you have on using the tool, that would be really helpful. Thank you. But I think that's it from me, so I'll just hand back to, oh, sorry, we've just got one question, so I'll just allow the microphone.
Hi Rachel, sorry about that. I had meant to say, likewise, if people are interested in the NHS tool, if anybody's interested in learning more about the prioritization tool that I talked about, then please do perhaps drop Rachel an email if that's okay. So we've just got the one email there, and then Rachel could forward the details on to me. That'd be great, thank you. Back to you, sorry Rachel.
So that's all from me, and I'm now just handing over to Erin.
Thank you very much to both Sally and Rachel for their time today. Can I ask everybody to send a round of applause to our speakers for sharing that information with us today, and to all the participants who shared those ideas and examples with us. Thank you so much for joining us today. And I'm going to turn it back over to Sally or Rachel because I see that Janet has a question. So I wonder if you could respond to Janet.
Hi, sorry, this is Sally. Janet, if you wanted to ask a question, please feel free to do so now. Press the little microphone button at the left-hand corner of the screen. Right, it doesn't seem to be working, Janet. If you did have a question, you can feel free to email us, or if you wanted to quickly type it in at the bottom on the whiteboard, please feel free to do so. Meanwhile, I'm going to pass back to Erin.
Thank you, Sally. I'm going to be sending through an evaluation form, and I'd be most appreciative if you could please take a few moments to return it and send it back to me. It really does help us when we get these evaluation forms to know whether you liked the speakers that we had, whether we were looking at the right sort of topics, whether the tools were useful, and so forth. These evaluations really do mean a lot to us. So I'm about to send that through. You'll see that coming up on your screen. So if you could please take a moment right now to open that and to respond, I'd really appreciate that. In the meantime, while we're waiting for those evaluations to come through, I see that Mary put a question on the chat board, so I'm going to turn it back over to Sally and Rachel to answer that question.
Sally, I don't know if you're able to answer the question. It's, if you update a systematic review for the new results which published before, what would be the title of the updated systematic review for the publication? I don't know if that's something you could address.
Yeah, sure. I think it probably depends. how much the conclusions of that review has changed. So if it's basically the same question, then I think that the title of the updated systematic review would be the same. Rachel made a comment on the whiteboard earlier just to say that all new updated reviews get a new citation. I think that's right now, Rachel.
Yes, that's correct. A new policy will be to cite all updated reviews. So as we were talking about barriers earlier on, this could be hopefully a potential barrier that might have been removed for updating Cochrane reviews.
And also for a carrot to try and hit people with if you're a managing editor trying to get people to update. Hopefully it'll be an incentive. Back to you.
Again, thank you so much to Rachel and Sally for taking the time to present today. Really appreciate having them both here to share that information and the different tools that they were discussing. So thank you very much to them, and thank you to everybody who was on the call today. Really appreciate you being here, and please do send through any more questions or comments. I'll turn it over to Rachel and Sally to look at Emma's comment.
And so Emma's just commented that she thinks the tools look great, but we'll need to think carefully about how to apply to the reviews. But it could give a spark for to actually sit down and discuss the important topic. So I think it would be great to hear, if anyone does use a tool, how they've incorporated it into their prioritization process for their Cochrane reviews, and it'd be great to get feedback.
Great, thank you. So thank you so much. We're going to be closing the session in just a few moments unless anybody has any other questions or comments that they'd like to make. Sally and Rachel will be on for just a few more minutes to wait for those to come through. But again, thank you so much to everybody for joining this session today.